For EMS providers, this is one of those calls that strikes a little bit of fear because they're so rare.
I remember a call on the radio from the charge nurse, "Get a gurney outside. She's giving birth."
You are listening to EMS with your hosts, Eric Axene and Matt Ball.
We got a great topic today, Matt. What are we going to be talking about?
OB. Well, we got a lot. We're going to talk about just general OB patients and kind of what happens to their bodies. And then we're going to talk about some common OB emergencies and management and all kinds of stuff. Yeah. 2-part series.
Yeah, on this parasitic infection.
Most women would probably agree with you when you say that. Yeah. If you're listening to the podcast, like, share, subscribe to our podcast. If you're listening for CE content, we're going to have 2 parts. So you'll watch Unit 1 and Unit 2. But our regular podcast, we're just going to roll through it, probably take a break in the middle.
It's a lot of information on this very complicated period in a woman's life, going through pregnancy.
A very complicated event in an EMS provider's life, too, when you get called out to that OB call. Yeah. This is probably one of those calls, I don't know as a physician, but, for EMS providers, this is one of those calls that strikes a little bit of fear because they're so rare.
From a medical perspective, they're really, this is one of those high litigation risk type things. A physician can get sued, specifically like an obstetrician, actually, I don't know if you know this, they can get sued for birth problems all the way up until the kiddo is 18 years old.
Oh, wow.
Yeah, so if there's something comes up as a problem down the road, you can actually, from what I understand, you could be held legally responsible for certain medical malpractice in the birth process.
Wow.
Postpartum, the stuff the obstetrician will take care of, all the way up until the patient's 18 years old.
Wow.
If those problems manifest. I think that's what I understand.
Right. And I think from an EMS perspective, it's, number one, it's a rare call. Delivering a baby or dealing with a small, neonate or something, and mom, obviously both. Right. But it's a rare call. But then anything to do with a baby or a pregnant mom, like everybody, I think most firefighters are protective by nature, and so you don't want to do anything to hurt a little tiny baby or mom. Yeah, we don't want to hurt anybody, but especially a little tiny baby and mom. So it induces a lot of stress, I think, with first responders.
We had a patient that had come into the ER, and it created a bunch of chaos. She actually drove her minivan up over the curbs in those the handicap spots and drove up onto the sidewalk in front of
in the ambulance bay?
Yeah. Outside the ambulance bay, kind of where the people park. Yeah. And I remember a call on the radio from the charge nurse, "Get a gurney outside. She's giving birth," and we delivered baby. It was twins, actually. We delivered baby A in the parking lot in the front bench of a minivan.
Wow.
And then got her over, after we delivered baby A, put her over in the gurney and got her inside to the ER. Mm-hmm. Baby twin B was breached, so we had to call in the obstetrician. Gosh. But everything went well eventually. But I remember that, like you said, these are crazy situations sometimes, and they can be intense and scary if you being prepared for these things. It's the low frequency, high stress sort of an event.
I usually tell my new guys, or when I'm teaching about OB stuff, is that this will either be one of the greatest calls of your career or one of the worst calls of your career. Yeah. And I've kind of had it both ways. We had an OB call, and we showed up, and the lady was, I think she was like 38 weeks, almost full term. And second baby, and we get her in there. She's like, water broke, contractions like a minute apart. We get her in the back, and I was never really of the mind. It's kind of a joke in the fire service, like, get the duct tape out, duct tape their legs together. We don't want to be delivered. They kind of freak out. I never really had that mindset. Like, and they talk about it a lot when you're taking those classes. And we talked about it in our CE lecture that. People have been women have been delivering babies in caves, for thousands of years. And so it's a very natural thing. Like, as a provider, you most of the time don't have to do much.
99% of the time, it's pretty straightforward. Exactly. You're literally just guiding the baby out.
Yeah, and clean it up, put it on mom. Like, nature takes its course, right? It's not a big deal. And that's how this one went. We got mom on the gurney, got her out to the ambulance, and we were going to the hospital. And we delivered going 70 miles an hour to the hospital.
Oh, wow.
She delivered a little baby boy, and one of the coolest experiences I ever had, because I called the hospital back, gave an initial report before she delivered, called back after she had delivered and said, hey, just so you know, we got the baby. And we pulled into the ambulance bay, and the whole ER staff was sitting out, happy birthday, and the doctors, the nurses. It was a neat experience for Mom. It was a neat experience for me. I thought it was cool. That neat. Mom actually brought him by several times over the next 3 to 4 years around his birthday. She would bring him by the fire station. We got to know him really well. But
that's special.
Yeah,
that's
it was cool. So,
yeah, we don't get that much in the ER because, we're just that transient place where we save lives and then we hand them off to people.
Well, that's what we do, too.
Yeah. Well, I mean, I think it's different, though. I think in the firehouse, you guys are... I mean, if there was a profession thought of as a hero, it's going to be the fire department. It's going to be the firefighters, I think.
Military.
Well, no, I agree. Gosh,
yeah,
they give their lives up for our freedom. I mean, that's true. That's a different brand of heroism, but societally, I think you're right up there.
Yeah, I mean,
as a firefighter.
I don't think most firemen would think of themselves as heroic, but there's an old saying from Easy Come. I don't consider myself a hero or something. I'm paraphrasing, but I work in the company of heroes. I don't consider myself a hero. Okay. I work in the company of heroes.
Well, that's how you are, though. You're humble, but you are.
Well, I think most.
But your profession in general is.
Yeah. I mean, it's the greatest job in the world. I mean, so anyway, we get to do some cool things, and that's. I mean, to be able to be a part of bringing a life, we get to deal so much when people are at the end of their life. Yeah. It's a cool experience to
bring somebody in.
Yeah, to be at the beginning of life, to see that happen, and it's much rarer than the other one. Yeah. So I looked at it as a cool experience for sure.
Yeah.
Everything went well. Obviously the baby was fine and everything, but yeah.
That's a good story.
Yes.
And those are the highlights of a career. You get to do stuff like that.
Yes, for sure.
And that's part of what we're talking about today.
Yes.
Is those are the great times, but every now and then things go wrong.
Yes.
And these patients, for lots of reasons, can be very difficult, and you got to really know what you're doing.
Yeah.
So that's what we're going to talk about today.
Yeah, some physiologic changes that go through that a woman goes through.
Yeah.
When she becomes pregnant. Walk us through that.
Yeah. Well, let's start with anatomy and physiology. So some of the anatomy. So the uterus increases in size. That little pear-shaped organ.
Yep.
Almost pear-sized too, increases 20 times.
Yeah.
20 times larger in pregnancy.
It's like a big old squash.
That's right. And the blood vessels, they increase too, right? So you get these tiny little arteries when you're not pregnant, but when you become pregnant, those arteries get really large, those uterine arteries. Right. And so you can bleed. Mm-hmm. You can bleed.
Yes.
And so hemorrhage becomes a big risk with that big organ, real vascular organ. You get the baby growing inside that placenta. There's a lot of anatomic changes with the cervix. Mm-hmm. A lot of anatomic changes. The organs shift around.
I was going to say, yeah. Yep.
And and the shifting of organs also decreases the size of the lung capacity, so you don't have quite the lung capacity that you do.
But you have more oxygen demand.
Increased oxygen demand, 20% increased oxygen demand. And you actually, even though you decrease, and we talked about this in our lecture, and this is a good thing to remember, it's a little counterintuitive, you decrease your lung capacity, but you're increasing your tidal volume.
Right.
So you're actually breathing more and larger,
right,
but you've decreased your lung capacity. So.
Right.
That and with the increased oxygen demand, it really creates some airway issues.
So that's one thing to think about, is that if you have a pregnant patient, oxygen is huge. Get them on oxygen, get them on FiO2. If you're doing positive pressure stuff, PEEP, is going to help with oxygenation because they're struggling. They need more help.
That's right. In fact, and you got to remember too that baby is there.
Yes.
You're treating two patients.
Yes.
And I read, any woman, any obstetric emergency, high flow oxygen's just got to be right there.
Yes.
Just do it.
Yep.
Increased heart rate, increased respiratory rate. We kind of talked about that.
Yep.
A lot of hormonal shifts.
Yep.
I think one of the interesting hormones is elastin. It decreases or increases, I guess, the elasticity of some of the ligaments, so the pelvis can be more flexible. And speaking of which, back to anatomy again, the pelvis is a whole lot different in a woman than in a man.
Yes.
From the birth canal.
Yep, exactly.
I think we hit up all the anatomy and physiology. Pretty amazing, though.
It is amazing what women's bodies can do when they become pregnant, and it's all the changes that they go through in order to create this life and grow this life inside of them. It's pretty, from a medical scientific standpoint, it's pretty amazing.
And I think one thing we don't appreciate enough before we leave the physiology and the anatomy, is the woman's body for that 4th trimester after delivery, for those 6 to 13 weeks, is getting back to normal again.
Right.
So when you have that postpartum woman, you've got to think about some of the things we're talking about today. Even though it's after baby's been delivered, we can't think to ourselves, she's back to normal, like a normal person. No, a postpartum woman's body's a little bit different. If there are things that can occur that we have to be aware of. And I think not just that, but psychiatrically too, speaking. Postpartum depression's a big deal. Yeah. And we have to be, I guess that we're not going to be talking a lot about that today, but the postpartum period for a woman can be very difficult.
Well, go back to our podcast with Chief Reardon from Duxbury, Massachusetts, and that touches on that topic extensively.
Huge.
So, yeah. Yes.
So I think that the anatomy and physiology, those are good. Now, what we're going to focus on now for the first hour are some of the general considerations we should have with a pregnant patient if they're in a certain situation. The first one we'll talk about is trauma.
Yeah, you want to, obviously, you got to remember, like you said earlier, they've got that little baby inside of them. So you're not just dealing with mom, you're dealing with baby and all those physiologic changes that happened. You've got increased dilation of blood vessels and stuff, a lot more risk of bleeding. So MVAs, different types of trauma, and universal. I mean, I would think it's pretty universal that, pregnant patients are one of those patients that no matter what you're transporting. You're taken to the hospital. Every protocol I've ever worked under, you are transporting, whether mom is, whatever mom's condition is, doesn't really matter. You're always taking mom to the hospital because of baby.
And then in the ER, now they're not all situations, but a lot of times I wait for the obstetrician to give me the kind of the approval, I guess, or the stamp of approval. Like, okay, this is safe to go home. Oftentimes we'll even obs them, especially with trauma, right?
Sure.
And you said it actually, 91% of all trauma is blunt. It's blunt trauma. That's what's going to get them. Hemorrhage can occur too. We'll talk about that. But when you have blunt trauma to the abdomen, whether it's a seatbelt sign or an assault or domestic violence or MVC, with that uterus as big as it is, I mean, it's a high risk for that baby to have damage to the placenta or the uterus.
Yep.
And that's what we worry about.
Yes.
And so we have to be looking for signs of hemorrhage. You may not see things obvious from your external exam.
Right.
Maybe the mechanism, and maybe you'll see some bruising. But you could have a normal exam and have what's called uterine abruption, or placental, abruption, where the uterus and the placenta are pulling apart from the trauma. And that could be
massive bleeding.
And that's obviously life-threatening for baby. And uterine rupture is another one, right? If you massive abdominal blunt trauma, you can rupture that uterus that's 20 times bigger than it usually is. Puts mom and baby at risk for different reasons.
And I remember in our whole blood podcast, we talked a lot about that's one of the main uses of whole blood in the field.
That's
is postpartum or just pregnant patients in general. Postpartum hemorrhage or trauma, something like that. So if you carry blood and you go on that pregnant patient, keep that on your radar.
A lot of the emergencies we're going to talk about with the pregnant women are their hemorrhage. It's something. What would you say, Matt? I mean, if you're going to teach a new paramedic or maybe an EMT about the signs of hemorrhage, how do you approach that as a teacher? I mean, I know what I do, but what do you do to teach hemorrhage, identifying a patient that's in life-threatening, hypovolemic shock, massive acute hemorrhage? How do you teach your new paramedics or EMTs?
So obviously if you can't see any external bleeding, so even a regular MVA where somebody sustained blunt trauma, look at their vital signs. Shock index is going to be a huge
shock index.
Obviously we know at basic EMT paramedic school, right? The heart's a pump, right? For our fire guys out there, if you need to increase your pressure, if you're losing pressure under discharge lines, what do? You turn your pump up faster, right? That's going to increase your pressure. Well, if you're losing volume, the pump has to increase its rate to maintain pressure, right? So the first thing you're going to see is that heart rate go up to maintain normal blood pressure. But then once you start losing enough volume, your pressure's not going to be able to maintain, and then your heart rate's going to continue to go up until you're in decompensated shock. You have no more blood pressure, and now your heart rate's low.
Yeah.
So shock index is that indicator that, oh man, we are not in a good place.
Nope.
And so obviously if you have signs of external hemorrhage, that's pretty obvious to
Tourniquet on.
Yeah, get
If
the
it's an
tourniquet on,
extremity.
get pressure on that wound, pack the wounds, whatever. But like with postpartum, or like anybody has an abdominal bleed,
You can't fix that in the
you can't fix that. But you can look for signs. Do you have a descending abdomen, a hot abdomen? Are they getting pain? We talked about that in our lecture about certain types of pain with GI bleeds.
Yeah, we should definitely talk a little bit about that. That's good.
But just look for signs of hemorrhagic shock. And your vital signs are going to be and constantly trending those vital signs. Like, where are we going here? Are we stabilizing, or are we continue to go the wrong direction? And then whether you're EMT or a paramedic, what do your protocols say? If you're an EMT, how close are we? There's so many factors that you have to take into account of, do we call for a helicopter? Are we just 5 minutes away? Are we at a level 1 trauma? Or are we out in the sticks?
Transport, yeah.
So many things to take into consideration when treating those patients.
That's good, and I like that. The way that I approach, it's not better, just different, is I try to help that new student understand what homeostasis is. Because the body is always trying to balance things.
Maintain,
Always trying to balance. And so right now you and I are pretty balanced, right? Yeah. And right now your blood pressure is pretty normal, heart rate's pretty normal, everything's kind of status quo. Your autonomic nervous system's kind of monitoring things and just keeping its tabs, watching the gauges in the cockpit of your mind, right?
Yeah.
And then you get in a car accident and you're bleeding, right? So now we're no longer in homeostasis. Right. To maintain homeostasis, or like a normal blood pressure, to perfuse your organs, if you're losing blood, we compensate. And the first thing that we see with hemorrhagic shock, it's actually not the first thing that happens, but it's the first thing we see on the vital signs, is the increased heart rate. And we did a light board for this, but you go through the stages of shock where you get to ultramental status.
Oh, yeah.
You're getting close to 40% or 30 to 40% volume loss.
Right.
Now you're getting into
danger zone. Danger.
So what is? I don't mean to put you on the spot, but what happens? Well, I'll just say it. The first thing that happens if I were to slice your radial artery in your arm for some reason, right?
And vasoconstrict and draw those arteries back in it.
That's right. So that'll help to slow the bleeding down.
And then your clotting.
And the clotting happens. Good. The clotting cascade, that happens before the blood pressure changes. The heart rate changes. Good. But the first compensatory thing that the body will do to maintain perfusion is to vasoconstrict the capacitance vessels in your legs.
Right.
That's where you store most of your blood.
Yeah.
And so it will actually shunt that stored blood up through the vena cava and maintain your preload. So for the first part of the hemorrhagic shock period, like before as you're starting to lose blood, the vital signs won't change at all. So the body's compensating by doing exactly what you said. Vasoconstriction. Gold star. Good job. You're not just a pretty face, man.
Not that either.
You are super smart. Yeah, no, that's a lot of people don't think about that. A lot of times, even you and I, when we teach hemorrhagic shock, we say the first thing that changes is heart rate.
Yeah. That's the first thing you're going to see. Yes, the first measurable change. Yeah.
And eventually, though, and what happens in the fire engine if you have to increase the RPMs on that pump, but you're losing water in the reserve tank, eventually you're gonna run out, right? What happens if you start running your pump and there's nothing there? You cavitate your pump, So same thing happens in the body. If you get too hypovolemic, eventually the pump cavitates. You cannot maintain pressure. And that's
called traumatic cardiac arrest.
That's right. So, there's really two options. You either slow the bleeding that's occurring or you fill up the tank.
Right.
You had to do something.
Right. And fill it up with what it's lost.
That's right.
So putting, just saline into the body is not replacing what it's. Saline does not carry oxygen.
Nope.
Yeah, you're replacing volume, but you're also blowing out that clotting cascade that's starting. Now you're flushing all that out, which is not helping your trauma patient or your hemorrhagic shock patient.
And not only that, we talked about this in our hemorrhage lecture when we played with the sharks, right? Is that you increase the
sharks. I refuse to be a part of that.
See, you're a smart guy. The permeability increases the permeability and the leakiness of the vessels too with the fluids. And as we've seen in the literature, I think they say with acute hypovolemic shock, 250 cc's of fluid may not be harmful.
Yeah, right. That's
basically the best.
Yes.
I mean, you may have to do that. It may be better than nothing,
right.
But you've got to get the patient to a place where they can fix the problem.
Yes.
And with a pregnant patient, the problem could be internal, with a giant uterus and a baby that's at risk. You got to know when to hightail it to the obstetrician to get to the facility where they can actually fix it. So that's trauma in a nutshell.
Yeah.
One other thing I'll say, though, with the organ shifting, if I was a pregnant woman, where are you going to put that needle for a tension pneumothorax potentially?
You're going to go higher.
You got to go higher.
Yeah.
You know,
which is always a good general practice. If you're not sure,
aim high.
Go a little bit higher than lower. Yeah.
But instead of the fourth or fifth rib space in that anterior axillary line, you might want to go third or fourth.
Right.
Yeah, exactly. Good. I think that's important to note. I think now trauma is a good conversation because of some of the anatomic and physiologic changes can create issues. Another thing to think about is sepsis. Sepsis is interesting. Women who are pregnant are at an increased risk of getting sepsis because their body's immunosuppressed to protect the baby. So women sacrifice their own health and their own, defense mechanism against getting sepsis by being pregnant as a huge risk. Again, another harm to the mom in this parasitic infection of pregnancy, right? So mom's immune system's ramped down, more at risk to getting sick. And again, sepsis, how do we identify sepsis, which I think is the key.
Right. Yeah, it's totally the key. Yeah, exactly. Again, it's very similar to trauma. You're looking at vital signs, right? Presumed source of infection, right? Every protocol reads a little bit different on what they consider that. Some protocols say just being a resident of a skilled nursing facility makes you a candidate for sepsis, which makes sense, right? But increased heart rate, typically like my protocol is a heart rate over 90.
Well, wait a minute, Matt. I thought you said that women are pregnant have an increased heart rate already.
That's right. They do. So you got to take
Makes
that
it even tougher, yeah.
That's right.
Yeah.
Makes it, but
excuse me.
We got dogs growling, water spilling.
That wasn't my stomach. That's a pit bull. That's
we got
right
a pit
down
bull on
there.
the floor. That's my buddy. So first off, presumed source of infection, right? Like ask. And I think this is something, a lot of pre-hospital providers take a little bit for granted, that they don't look at that heart rate and that blood pressure and that respiratory rate, right? Look at what happens when our body is fighting off an infection, right? It's the same thing. Your heart rate increases, your respiratory rate increases because internally that's why we get a temperature, because our metabolism is sped up. So we get an increased temperature, right? So you got to look at all those factors and think like, did mom potentially have a source of an infection here? And then you look at the vital signs. If heart rate's maybe over 100 now, or maybe over 110 now, or ask mom, hey, what's your heart rate normally run? Is a good gauge, because everybody's a little bit different. Since you've been pregnant, what has your heart rate been running? And so look at that. Use that in comparison. Look at the respiratory rate. End tidal, like we've talked about numerous times with sepsis, is a huge indicator of what stage of sepsis, first off, is it sepsis, and then what stage are they in? So again, you have to take all that into context. Does mom have a fever? Obviously a huge sign of an infection risk. And then follow your protocols on where to take them, how to treat them. Fluids are going to be a big deal. With that, they have, they still have blood, but they're leaky, right? So saline in that situation, at least right now, is you want to give them fluids. They need volume. They're not losing blood. They just need some volume.
Yeah, they need volume. You lose, and see, for the woman being, metabolic demand is much higher. She's got two bodies to take care of.
And now she's sick, so it's even higher. And now
she's sick, that's right. And we have a tendency as providers to see a late-term pregnant mommy, and we anchor on pregnancy.
Yeah, the belly. Oh my gosh.
Right? That whole
Please
mentality.
Don't have this. Yes,
right.
Yes.
And that can actually interfere with what our job is, and that is to identify disease. We miss a lot of sepsis. And now we've got a woman We're focused on the giant baby belly,
Yep.
thinking, please don't deliver now.
Well, and of course your heart rate's 120. She might be having a contraction.
Exactly,
Yeah.
and she's late in pregnancy.
Of course she's breathing faster.
Right.
She's hurting, yeah.
All this is a physiologic response to the pregnancy.
Yeah.
So sometimes we can see these abnormal vitals and be like, oh, it's pregnancy,
Yeah, it's
right?
just
It's
pregnancy.
and forget to check a temperature
Yes.
or whatever it is. But a woman who is pregnant and sick because of her being immunocompromised, now she's compensating. Now her vitals are already abnormal. Now they're worse, right?
Right.
These, again, that pregnancy can get in the way. We can't anchor on the pregnancy. Pregnant women can have emergencies just like us. They got meningitis.
Yep.
They can have any sort of a septic, sort of a source infection like you talked about. Women actually are at increased risk for urinary tract infections too.
Yeah, UTIs. Yeah.
And remember, the immune system's ramped down, so they're easier to get sick. So we've really got to keep our beepers on for looking for sepsis in the pregnant patient population.
Yep.
So in management, you started to talk about it.
Yep,
Fluids are important.
Yep,
If you have IV antibiotics,
Yep.
give them.
Yep.
If you
Get
need it.
Tylenol for pain, for the fever.
Yep.
Safe to give in pregnancy.
That's a good question. I know there's been some literature out
Yeah.
there. The association is pretty strong with the. So we don't want to get into the
weeds.
pharmacokinetics.
Kind of threw that one on you real quick with that.
No. I mean, I think it's good that you bring it up because we have to look at the literature and be honest, right?
Right.
Unfortunately, in our society right now, somebody on one side of the aisle says something, the other side of the aisle says you're an idiot.
Yeah, exactly. Yeah.
So let's not think about politics at all right now.
Right.
This literature came out of Harvard.
Yeah.
I'm glad you brought it up, actually, because this is interesting, I think. But this literature came out of Harvard where they found an association, not causality, but an association with autism. And there's actually a couple things. It's not just Tylenol. There's some other stuff, too, with the folate, the methylfolate. But anyway, that's another issue. But so Tylenol creates a pretty nasty poison. It's a known poison. And we have this enzyme in our liver that detoxifies that. And with glutathione. And but if you take too much Tylenol, that stuff can linger and create lots of problems. That toxin, NAPQ, it's called. Well, for some reason, there's an association with Tylenol in the prenatal phase, associating those kiddos with the autism. It was a meta-analysis, a bunch of studies that showed an association with it. So if you read RFK's issued memorandum through HHS, it was just he wasn't saying not to do it, he was saying beware. Beware that there is an association. So he recommended, and I think it's good that obstetricians do this, is just look for alternate pain medications, look for alternate ways to treat mom.
Well, I'm not talking about for pain. I'm talking about septic
true.
mom patient with
Septic
raging
mom.
fever, pre-hospital environment.
Yeah,
Because it's got a risk versus benefit.
If you and I were riding out and teaching our paramedics, we'd have a great discussion about this.
Yeah.
We don't have time to get into it
Yeah.
today. But you got to weigh the risks and benefits.
That's
Yeah. Like
how
you
sick
said.
is mom? How bad's her fever? Are there other ways we can bring it down? Obviously, follow your local protocols.
Yeah. So giving any medication is not benign.
Right.
There are always side effects to all medications.
Right.
And I'm grateful for this new literature that's come out. We have a better understanding as we develop, increase in technology, and understand the literature and a lot of scientific discoveries. We can make smarter decisions and be better caretakers of our patients. And so this is a consideration, is protecting baby, and that's a lot of what we're talking about today. Is
Mom and baby.
Yeah, mom and baby. We got two lives at stake here, and we got to think about all these things.
Yeah.
So, good question, though, sepsis. I actually questioned giving Tylenol long before this literature came out. For decades now, I've been recommending as a physician to my patients who have a kiddo that's got a fever. It's like, don't be so quick to just give them Tylenol or Motrin or whatever.
Yeah, let them fight it a little bit.
Don't give Motrin to a pregnant woman, by the way.
Yeah.
But it's getting a fever is a good thing. When you're fighting off an infection, it increases your oxygen offload capability. It essentially increases your oxygen carrying capacity to offload more oxygen from hemoglobin to the tissues. Our immune system uses oxygen as like a bullet. It's like the ammunition of the soldiers that we send, those neutrophils and macrophages and phagocytes and all sorts of stuff. They use the oxygen-free radicals like a bullet to kill the enemy. And part of the way we get all that oxygen to the tissues is by increasing our body temperature. It shifts the oxygen dissociation curve.
Right.
And so oftentimes, I don't go into the detail with the mom. Let me draw a picture of the oxygen dissociation. I just tell them, I say, don't just willy-nilly give your kids Tylenol when they get a fever.
Right.
Because if my kiddo has a fever and he's playing Legos,
he's fine.
I'm worried about the fever. It's like, oh, shoot, our kid's sick. But he's playing Legos.
He's fine.
Like, that's a vital sign too, right?
Yeah.
Don't give him Tylenol.
Yeah.
No, you got a really sick kiddo that won't get out of bed
miserable,
and won't
crying,
eat and won't sleep. Give him Tylenol, Motrin, whatever.
Yeah.
And now, again, got to consider the risk-benefit with any side effect. But the same thing's true of the pregnant woman, right?
Yeah.
You have to consider the fact that this fever is actually helping to fight the infection. So what's the risk-benefit of giving the Tylenol?
Right.
I don't know that I would.
Yeah.
I don't know that I would. I think get to a certain fever, you run
That's
the
what I'm
risk
saying.
of,
Yeah, if you were 103, 104, you might be considered. But 100.4, I know, is usually a cutoff for sepsis where we would give Tylenol.
I think 105 is kind of the temperature that I get concerned at.
Yeah.
But 103,
That's
104, I mean, follow your local protocols.
Right.
But
and as a pre-hospital provider, you can always call your medical director. Call Med Control and say, hey, this is what I got. If you have Tylenol available, how would you like me to manage this patient? But good conversation. Good talk.
Pain management is another issue. Opiates are kind of standard of care. I mean, I know we just started IV Tylenol not too long ago, so there are other options. Ketamine is another one.
Yep.
Safe in pregnancy.
Yep.
A lot of research still coming out there, but follow your local protocols.
There's a lot of research on ketamine coming out. Yeah. All different kind of things.
But I think standard of care for pregnant women, opiates would be it. Just be aware of the fact you could suppress the breathing, driving baby if you're going to be delivering. And actually, MAG does that too. So be aware if you've just given MAG because of an eclampsia or whatever, that baby's not going to potentially be breathing right.
Yeah, make sure you have them on oxygen if you're doing any of those things, and tidal to watch their ventilatory effort for sure.
The one of the topic we had was a cardiac arrest too. A woman in cardiac arrest. I've had multiple, unfortunately, women in cardiac or pregnant women in cardiac arrest, and it can be a scary situation. Again, 2 lives, right?
Yep.
And you get a pregnant woman in cardiac arrest that's term, you can save both.
Yep.
You can save both, but at some point, you may have to do a hysterotomy. You may be getting baby out, right?
Pre-hospitally?
Not pre-hospitally.
Yeah, I was going to say.
Yeah, not pre-hospitally. Sorry, I'm thinking about the ER.
Yeah.
The perimortem C-section.
Yeah.
That being said, boy, then, if I ever got an online call from my guys in the field telling them what to do, I mean, you may need to do that.
I heard of one similar. I won't get into details about it, but it was discussed. I'll say it was discussed of maybe because of this very unique, unfortunate situation, it was discussed that the medical director was almost thinking about allowing them to do that because it might have been the only shot period for the baby. But I mean, yes, it's probably not going to be standard of care anytime soon in the pre-hospital environment for sure.
No, if you've got a traumatic cardiac arrest and a pregnant woman in a car accident, for example, you've got about 4 minutes.
I was going to say,
I think it's less than 5, 4 or 5.
Yeah, I think that's what we looked at.
That's what we taught, right?
Yeah, in our lecture.
That's right. So if you want to do the perimortem C-section with the obstetrician and get them to the hospital, it's got to be within that 4 minutes.
That's crazy.
I think it was 4, maybe 5, but it's quick.
Not a skill I really want to perform.
No. And you got to call ahead. Hopefully that OB's in house.
Yeah, do not do this without permission.
No.
Let me reiterate.
Do
not do that without permission.
Follow your protocols.
Do not start cutting open pregnant patients.
Absolutely, yeah.
Yeah.
No, follow your protocols. But this is a rare situation
Very
where
rare, yeah.
mom is non-viable, so we do chest compressions just to maintain some semblance of cardiac output for baby. But to avoid the anoxic brain injury, we have got to get baby out fast.
Yeah, and if you have ultrasound, you can check for the viability of the fetus and see if you're trained, even if you're trained on doing that,
Yep. And even if baby looks like heart's beating and looking okay, if mom's in cardiac arrest,
it's not going to last long.
You're going to have the anoxic brain injury in that kiddo. That's against the cause of cerebral palsy and then multiple other problems with baby we want to try to avoid.
Yep.
But it's not uncommon, though, to go into cardiac arrest, and there's again, like we talked about, the immune system. The body's immune system being ramped down in that postpartum period. These postpartum women are at risk for a postpartum cardiomyopathy. It's not common, but relatively speaking, for pregnant women in that postpartum period, with the immune system ramping back up, you can get a postpartum woman in cardiac arrest from really like an acute onset heart failure.
Right.
I've lost a couple patients I can think of off the top of my head who died from postpartum cardiomyopathy. My wife, she's suffered from some of the effects of a postpartum cardiomyopathy. Fortunately, she got her ejection fraction back for the most part, but it's not a benign thing for pregnancy. It's a pretty big deal.
Yeah. Oh yeah.
So for the last part, I have a few cases here. Oh, you know what? Actually, should we do the bow chops thing?
Let's do it.
Yeah, so
bow chops.
Yeah, things to consider with a woman in cardiac arrest. The O in bow chops is the other, which is the H's and T's that you normally would consider in anybody. Right. You got to still think about those, but with the pregnant woman, you've got to think of bleeding as the reason for being in cardiac arrest, and most of the time, that bleeding you can't fix.
No, that's going to require surgery. Yeah.
Embolism. Women, because of all the hormonal shifts, are in increased risk of getting a pulmonary embolism, which isn't part of the H's and T's typically. Right. But the other thing that's interesting is the amniotic fluid embolism. You can get that amniotic fluid embolism into mom's circulation, and that can be really, really bad. Yeah. There are lots of different types of embolisms. You get lots of fluids into the vasculature that aren't supposed to be there. It can be bad. In fact, I had a firefighter who was injecting steroids, testosterone. It was a Freudian slip. And
wait, I mean, this is just so rare. A firefighter that uses testosterone? Come on. That never happens.
No, it's a real medicine. Physicians, we prescribe this for people with low T, and there's reasons to do it, and there are health benefits to it. But if you're injecting this stuff, this guy just didn't he'd never been taught to aspirate first when he injected himself. So he's just going in and just injecting. Well, he got into a pretty major vein, and he got short of breath. Anyway, it's a real deal. Oil. It's an oil embolism. Yeah. Is what it is. You get a bunch of oil in your lungs, and it probably won't kill you, but you should. That's. Anyway, it could kill you actually, but anyway, the point is, women have that amniotic fluid. Right. They've got hormonal shifts that can create blood clots. You don't want to throw stuff into the alveolar beds when you're trying to breathe.
It's not supposed to be
whether it's oil, amniotic fluid, or whatever. Blood clots that can be life threatening. So that's the E in bow chops. Anesthesia. This is more postpartum stuff, but that's something to think about. Here's a big one. We're actually going to talk about this in the next hour, so we won't go into detail now. Is uterine atony. That uterus doesn't constrict back up. The vaginal bleeding can continue and become life-threatening. That postpartum hemorrhage. Cardiac disease. We kind of talked about that. That's the C in CHOPS. H is hypertension. Actually, we're going to talk about that too in the next hour. We're going to talk about preeclampsia and eclampsia. With other H's and T's like we talked about. Placental abruption and rupture. We kind of talked about that here, but we're going to go into more detail in the next hour again. And then sepsis, the S. We talked about that. We didn't talk about that anymore.
Yeah.
All right, case number 1.
Okay.
So, a 31-year-old pregnant female. It's her second pregnancy right now. The first one, she had a miscarriage.
Okay.
Call 911 for severe shortness of breath. What are you thinking?
Thinking I got a 31-year-old female that's 31 weeks pregnant with shortness of breath.
Well, I know what you're going to do right away. You're going to put them on oxygen.
Yeah, for sure.
Yeah.
I'm probably going to try to get a room air set just to kind of see what are they at. But yeah, I'm certainly that's on the radar. Not putting the blinders on because shortness of breath could have a lot of reasons. She could be bleeding. She could be septic. She could be a lot of different things. It could just be decreased lung capacity and increased oxygen demand.
So I'll get her on the vitals. I'll get you your vitals here. So while I'm getting a vital, you're going to get history. What are you going to ask your pregnant patient?
Well, we already got her pregnancy history.
Yep.
Right? Any recent history of trauma? When did this happen? When did she become short of breath?
Nope. No history of any trauma. Been getting worse. My shortness of breath has been getting worse over the last couple days.
Does she have any history of asthma? Any
no
respiratory
medical
issues?
problems?
Nothing at all.
Nothing.
Allergic to any meds? Nothing.
Nope. Not allergic to anything.
So this is
I'm
just
only on my prenatal vitamins. I'm 34 weeks pregnant.
34 weeks pregnant. And this is the first time this has happened during the pregnancy.
Yeah. I've been having a lot of chills and I've had trouble sleeping at night. A lot of backaches. And,
okay.
So I'm it's been the last couple days.
Okay. So
I got your vitals now. You ready?
Yes.
Heart rate 125.
Okay.
What do you think of that?
What's her baseline? That's high.
Exactly. It's a little high, but
nothing crazy, but
it's high.
Anxiety's probably up too. So
yeah, that's the other thing too. Is like, how do you differentiate tachycardia
from just regular old she's nervous?
This guy was just in a gunfight. It's like, of course he's going to be tachycardic.
Yeah, just finished a workout.
But he got shot too, so
Yeah.
Could be.
Got to look at the whole picture.
You said it earlier, actually. I think this is probably one of the most important things to remember as we talk about these cases is to reassess.
Oh, yeah.
To get a trajectory, lots of vitals, lots of points of time.
Yes.
Heart rate's going up.
Yeah, what do we do? Yeah, exactly.
Patient's altered now.
Blood pressure's going down. Heart rate's going up. Ooh, respiratory rate's increasing. Yeah.
So this is the first set of vitals you got is 125.
Okay,
a little tachycardic.
Yep.
Blood pressure's 95/60. Okay. What do you think of that?
A little on the low side, but it's not crazy.
No, and in pregnancy, remember
125 divided by 95. What's that number? I don't know. You're the math whiz.
Yeah, that's shock. It's positive shock index. Yeah, but a perfusing blood pressure in a relatively healthy person is probably around 70, 75.
Right.
Some might say minimum of 65, but at least between 65 and 75 MAP, mean arterial pressure.
I was going to say MAPS, not systolic blood pressure,
If I take 95/60, it's going to be in that range.
Yeah.
It's going to be more than 60.
Yeah.
And so we actually may have a normal blood pressure, but tachycardia, remember like we talked about, the first thing that changes, right, is the heart rate.
Yep.
I can't think of a reason why we'd be bleeding here, but she is pregnant. We better ask those questions. 30.
What's her temp?
I haven't got the temp yet, but SATs are 90%.
Okay, so that's concern.
Sorry, I read around 98%.
Oh, 98%.
Yeah.
Okay.
She's got back pain.
So 98, but breast sounds?
Lungs are clear.
Okay. Any history of infection, UTI, anything?
I've been having pain urinating.
Okay.
Yeah, and my back hurts though.
Does she feel warm to the touch?
She does.
Okay.
102.
Okay, there we go.
And title's 23.
Okay, yep, she's septic.
Yeah.
Until proven otherwise.
Yes. And then I think because she's pregnant, you got to be careful, right? So as mom's compensating for her sepsis, we got to keep our eye on the other life there too. Yep. So I think high flow oxygen's key.
Oxygen, IVs, fluids aren't going to hurt her.
Yep.
Her blood pressure's not, it's not super low, but it's not high either. So, but I'm also going to watch the breathing, make sure fluids don't add additional breathing issues. But yeah, sounds like a septic patient to me. Yep. If that end tidal stays over my vital signs that I'm checking every 5 minutes, if it stays that low, but IV fluids, oxygen.
Good.
Probably not going to give the Tylenol right now.
What fluid would you give if you had
Ringers.
LR and
Ringers?
Yeah. That would be better for sepsis. Yeah. A lot of agencies don't have that option. Most go with just NS. That's better than nothing. Yep. Antibiotics if you have it.
Yep.
So you give those IV fluids, and her blood pressure just keeps going down. Heart rate's going up. what would you go through next? At what point do we decide to do pressors?
Yeah, leave-fed. I'm going with some leave-a-fed to get her. Yeah. I'm not worried about the heart rate's fine.
Yeah.
Trying to get that vasoconstriction to keep that pressure up.
Yeah.
Watching that map on my monitor.
Yeah.
Yeah.
Be interesting to see studies on pressors. I didn't research this, but I'm going to give pressors to a woman, pregnant woman, regardless.
Well, I mean, if you lose
blood
mom,
pressure up.
yeah, if you lose mom, and I mean, if her blood pressure is low, how's baby perfusing? We have no way of monitoring.
I just wonder I didn't research this. I'm just thinking out loud right now. But which pressor would I choose if I had choices? In the ER, we got all the pressors, right? So
right.
I'm thinking, which one would I do? If you only have one, give it.
Yeah. Yeah.
I can't think of a reason why one would be contraindicated, but there may be a benefit of one over the other, whether it's epi versus norepi versus dopamine.
Yeah, if you're just going for that, like I say, the heart's doing its job, so it doesn't need any chronotropic help. It just needs some vasoconstriction is what I'm looking for to hopefully get the pressure up.
And I think one of the most important things we do with anything in the pre-hospital environment, you've done it, is identification.
And take them to the right facility.
And take them to the right facility. And do what you can do.
Because you have a viable fetus here.
Yeah.
You know, the 31 week, that's a viable fetus.
Yep.
So make sure you go to a facility that has a NICU because it's coming a little bit early, might have some issues, and you want to have the people there that are experts in this area because we're just shotgun medicine and figuring it out. I want an expert up here.
Yep, that's right. And you follow certain hospitals will send anybody over 20 weeks straight up.
Yes. Yeah.
And unless there's something life-threatening going on, right? So. Right. But follow your local protocols on this, and then identification again is key. We miss a lot of these, and in pregnant women, we focus sometimes on the pregnancy. Oh crap, the pregnancy is not the issue here. It may have caused it indirectly, but it's the sepsis, right?
Yes, yes, so. For sure.
All right, you ready for case number 2?
I guess so.
Okay,
it's coming.
All right, so you're dispatched to a 28-year-old.
Okay.
First time pregnant.
Okay.
Primogravid.
Okay.
For seizures.
Okay.
So you're currently. And actually, we're going to switch gears a little bit here because we didn't talk about eclampsia, preeclampsia.
Switch gears.
Because these are a little out of order from the way we did it in our lecture. But
hey, you never know what you're going to get called out to, so you got to be ready.
So let's say you treated with the MAG according to protocol.
And we'll talk about that in a second.
In the second,
yeah.
And your patient's heart rate's 140. Blood pressure's 150 over 90, which is high from the eclampsia. And respiratory rate's 40. SATs are 82.
This is after the MAG?
This is after the MAG.
Yeah. Well, I would have already had her on oxygen.
Yeah,
so
you're
if
on.
She's not on. Oh, and it's 82 on.
No.
Okay.
This is before, so I would definitely put her on high flow.
100%.
Yeah, absolutely. And a physical exam, everything is not looking good. She's pink, frothy sputum, altered, crackles in all lung fields, and she goes pulseless on you.
Okay. Well.
Why did she go pulseless?
Looks like we're starting chest compressions.
Yeah, this is the preeclampsia we're going to talk about later. In eclampsia, you go into seizures. It is not a benign thing. No. This is a life-threatening condition. You got to get baby out.
Yes.
And so this mommy, actually, this is a true case that we covered in our lecture. And mom and baby survived.
Yeah.
But did go into cardiac arrest. And MAG actually too. It can create some issues we mentioned earlier with breathing for baby, but it is an association as a MAG associated cardiac arrest in eclampsia. So anyway, interesting case.
Yeah.
Interesting case to think about, and we'll talk more about that in the second hour.
MAG versus benzos. That's a big conversation with eclampsia.
And ketamine too, right?
Yeah, and ketamine. Yeah.
All right, last case here, and then we'll
wrap it up.
Take a little break, before Unit 3.
Yeah.
All right, Matt, a 27-year-old female, 5th pregnancy.
Oh, gosh.
This will be her 4th child.
Okay.
One miscarriage.
Okay.
She's a driver in an MVC, 38 weeks pregnant. Patient's complaining of abdominal pain and left shoulder pain.
Okay.
So, what are the things that we learned that we should be thinking about in a trauma patient?
Well, I am extremely worried about hemorrhage. Because number one, she's pregnant. We've talked about that. Number two, she's complaining of left shoulder pain. So I'm a little bit worried about her spleen with referred pain. So I'm really worried about bleeding. I'm also worried about baby because if this is number 5, she's very prone for that baby to come out quick.
Baby's ready.
So we got a lot of things that we're looking at here. So is she removed from the car? Does she require extrication? We get her out. We get her on the cot. Hopefully.
Yeah, she's out. You're in the back of the ambulance right now. She's got no medical problems, just her pregnancy.
Give me vitals.
Takes prenatal vitamins, no allergies. The airbag did deploy. The patient was restrained. She did not lose consciousness. There were no other occupants in the vehicle except for the baby in utero.
Yeah.
And vitals. Heart rate 110, blood pressure 95/65, respiratory rate 25, O2 sats 99%, no fever 98.6, end titles 30. We actually talked about the end tidal too. Remember, end tidal targets are a little lower in the pregnant.
In the pregnant population.
Yeah. Anyway.
Well, and she's also breathing a little bit faster, but that could be due to anxiety because she just had a car wreck. So
Absolutely.
I'm not freaking out over any of those numbers right now.
But you're going to watch and you're going to reassess,
100%.
like we talked about.
Yes.
Yeah.
And she's having abdominal pain?
Yeah, abdominal pain. So
Where's
you want
the
to do
pain?
physical exam?
Yes.
So you see a seatbelt sign. You got a bruising across the lower abdomen below her gravid uterus, and then she's got a seatbelt sign across the left chest from the seatbelt, obviously.
Okay. So is the left shoulder pain like clavicle pain, or she?
No, just it just hurts over there.
Okay.
This patient I remember that I had, it ended up not being anything, but they ended up keeping her in the hospital and they delivered. But
Just to watch, yeah.
But in this particular case, just like you said, we're going to continue to monitor them,
Yes.
right? So you do your physical exam. You've identified a potential emergency with the bruising. When you get that bruising patient, pregnant or not, that bruising pattern is a big
Significant.
danger, red flag.
Yeah.
The energy it takes to make that kind of a seatbelt sign can rip spleens and livers. And,
Aortas.
yeah, it's dangerous. So in a pregnant patient with a giant
Placentas.
uterus, yes, exactly. We got to think about placental abruption. We got to think about placental rupture.
Yeah.
When you push on, you mentioned this earlier, we should talk about it. When you push on a patient's belly, there are different brands of tenderness.
Right. Different brands.
When you explain, I have pain, that's subjective.
Yeah.
But when you touch a belly, it's actually quantitative.
Yeah.
And we in the ER would ask you, if you told me that her belly was tender, by phone maybe, I would ask you, is she guarding?
Yeah.
And I would ask you too, is there a rebound? Those are the signs of what we call peritonitis. You get blood in the back of your abdominal cavity. It's called the retroperitoneum. Yep. It is incredibly painful.
Yes.
You don't want anyone to bump the bed. I mean, you are in so much pain.
Yes.
That is a different brand of tenderness. And if a woman's bleeding internally, gosh, in this context with a 38-week gestation, you're in big trouble. So just like what you did, the patient's complaining of lightheadedness now.
Okay.
And so you want to repeat the vitals.
Oh, yeah.
So what do you expect?
Well,
the
I
heart rate?
actually want to be going to the hospital.
Yeah, we're on our way.
Yeah.
Lights and sirens.
Yes.
And the heart rate's up to 130 now.
Okay.
Blood pressure's down to 85/60. Respiratory rate's up to 35. O2 sats have maintained, no fever, and the end tidal is coming down. And that makes sense, right? We're breathing faster. This is not moving in the right direction.
Yeah, I definitely want her on oxygen. I don't really care what her sats are because it's not a real-time vital sign. So I definitely want her on oxygen. IVs, and I'm maybe thinking TXA on her.
Yeah, I think so too. I think TXA, you got to think
Unless I
about
had
that.
blood.
Yeah, unless you have blood. Absolutely. Because you can't fix it, but you can slow it down.
Yeah.
Actually, I think that's it for the case, but let me ask you a question if you know this.
Okay.
But just to close the case out, you're right, destination's huge, right? This 38-weeker, given TXA or blood might be the only thing that we can do. If you're a BLS provider, you can reverse Trendelenburg, get the legs up, and lay them on their left side, right? Yep. Don't occlude the vena cava.
Right.
But TXA, let's talk about TXA as we close this thing out. Do you know what TXA is? This is really interesting.
Acid.
It is, yes, that's TXA. Nice work. Well,
but let me go back to my education. So the body's natural clotting factors, right? It slows down the breakup of the clots, right?
It stabilizes the clot.
It stabilizes
that's right.
the clot.
That's exactly right. Good. Yeah. In fact, what I learned, I didn't know this before, so I'm sharing something I just learned too. It's really interesting. So in our body, lysine is an amino acid. That's an essential amino acid.
That's what breaks down the clots.
We can't
right?
make it. No, it doesn't. Actually, what lysine, the amino acid, does is it inhibits plasminogen and fibrin or whatever.
Right. That's right.
To break the clot down.
That's what. That's
what lysine does.
Yes,
this amino acid. And so what TXA it's an analog of lysine.
Okay.
It's basically a pharmaceutically derived amino acid.
Yeah. Okay.
That's what it is. It's interesting. I didn't know that. But that's essentially what TXA is. It binds to that receptor to. It basically inhibits the breakdown of the clot by getting in the way, and that's what lysine does. The amino acid, essentially, and so TXA comes in, stabilizes the clot so it doesn't break down. I thought that was kind of interesting.
Yeah.
It was it just goes to show you, we're really smart, medical stuff, technology, right?
Yeah.
But we're just trying to mimic the body.
Oh,
the body is
the body's natural way of doing things. That's exactly right.
I
Speed up the heart rate. Clamp the vessels. Yep.
I learned a lot in preparing for all this stuff.
Yeah.
This is really amazing, and the whole process of pregnancy is amazing. To discuss it with you on this podcast today, this is
amazing.
It is, and the topic is amazing too.
It is. It's
not
a good
just
topic.
you. It's,
no, it's a good topic because, like I said, this creates a lot of anxiety for in-hospital and pre-hospital providers. So it's important that we're constantly studying up on these things and putting this back on our brain because you never know when you're going to get that call to handle one of these situations.
That's right.
Yeah.
And in this hour, we didn't even get to the birth process.
No,
we're just talking about the pregnant body and the physiologic and anatomic changes, which is phenomenal and amazing, like you said. But and then we talked about some of the implications with trauma, with sepsis, with pain control. Ran through a few cases, but we really haven't even gotten to the actual process of birthing yet, of delivery. So we'll do that in the next hour.
Yeah, we'll take a break and we'll do that in the next half.
Thank you for listening to EMS, the Eric and Matt Show.